For the next talk, I invite Dr. Kameswari. She is the head of the Department of Gynecology at Fernandez Hospital, Hyderabad. And she'll be talking on the trending approaches, that is non-surgical management of fibroids. Over to you, ma'am.
Very much. Very good morning to all of you, respected chairpersons, delegates. It's always a great pleasure to be part of Toxicon because of its educational value. I always go home taking a few learning lessons. So fibroids, all of us, this is the bane of our life. If a patient with fibroids sits in front of you in the OPD, you don't know where to start and where to end. Almost 80% of women have fibroids, very common in Afro-Caribbeans. We still don't know the exact cause of it. All we know is that they secrete lots of collagen and they resist cell death, that is apoptosis. Leading cause of hysterectomy, sometimes unwarranted, with a lot of huge cost implications. When I was preparing this talk, I had two revelations. Not that you don't know about it. There's a lack of solid medical solution to the commonest benign tumor in women. Women come and ask, can't you give medicine and get rid of it? We don't have it. Why did we stop looking? No, there are lots of medications in the fray at different research levels. But at the end of preparing the talk, I'm going to make you none the wiser. I'm not going to give you any magic bullet to treat the fibroids. These are the two revelations. So if you have come with expectations, then I'm really sorry. There are no new drugs still added to our guidelines. Risk factors we all know, who gets and how many. The classifications we are all aware. The FIGO classification is the one we all follow. And how do fibroids impact health of women? Usually it is excessive bleeding, leading to anemia, pressure symptoms, urinary, bowel symptoms. Fertility is compromised if they are submucous or if they are too large or if they are blocking the tubes. Sometimes they're present in pregnancy and cause a lot of problem to us, different dilemmas. And remember, 50% are asymptomatic. You don't really have to do anything. So when you want to plan treatment, you have to base your plan on the problem that we face. Is it the bleeding? Is it the bulk? Or is it both? And as a second step, it's useful to know the patient's desire to conceive again. So what are the options we currently have? We have medical options. There's a big list, as you can see there, but how many really are useful? We'll get into that. So non-hormonal, hormonal, and experimental drugs. Interventional radiology is taking up a lot, uterine artery embolization and MR-HFUS. Of course, we're not talking about surgery today. We are talking about non-surgical management. So at the moment, when do we use medicines for fibroids? For symptom relief of heavy periods, as a temporary measure when they're just at the brink of menopause, or preoperatively to decrease the size, to decrease the bleeding, to improve the hemoglobin. These are the current indications of medical management. What are all the drugs that we know can be used? OC pills, progesterones, NSAIDs, Tranexa, that is antifibrinolytics, danazole, IUCDs, progesterone IUG, SPRMs, GnRH agonists. Till here, I'm sure all of you would have used one or the other for one of your patients. What are the newer options? GnRH antagonists, SERMs, aromatase inhibitors, growth hormone-directed therapies, antifibrotics which inhibit collagen, nanocarriers. These are smart carriers that carry drug depots into the fibroid under ultrasound guidance, so they work there for longer time and shrink the fibroids. Vitamin D is there everywhere. Gene therapy, herbal medicines, but none of these have reached the guidelines because of either lack of robust evidence. Still phase 3 trials are going on. So I really can't recommend one of these at this stage, but you need to know. So given all these options, how do you apply to your patients? So we look at a few case scenarios. The commonest, you get these teenagers with heavy menstrual bleeding. You do a scan, and there you go, you find a fibroid. So what are you going to do? And she will have it in her brain, oh, this is the cause. But what are our options? Non-hormonal are tranexamic acid or mefenamic acid. And nowadays, we are recommending you test anybody, vitamin D is low. So it's implicated in many things. Green tea is supposed to reduce the growth of fibroids. So these are the non-hormonal options for her. We know how they work. They inhibit cyclooxygenase, reduce dysmenorrhea and bleeding. At the same time, they do not do anything to the fibroid. Remember, you should educate your patients. The medicine you're giving is only for symptom relief. The fibroid is going to be there, and we have to watch it. Tranexa, we know how it works, commonest drug used to reduce bleeding. Vitamin D has anti-cancerous effects, inhibits growth, it promotes cell death, therefore found as one of the options, safe and low cost. It reduces proliferation and increases apoptosis. Also growth factors expression is reduced and therefore volume reduction. Green tea is an antioxidative, anti-carcinogenic medication, reduces fibroid size and severity of symptoms, but we still need more evidence. If she doesn't respond to Tranexa, can we give her any hormones? Yes, OCPs are the commonest ones that we prescribe. We can also use progesterone-only pills or injectables. Now another 34-year-old lady who has one child and not currently planning, has severe pain and heavy periods with an intramural grade 3 to 5 fibroid. How are you going to approach this lady? The same options that we told for the teenager apply to this lady as well, but you would tend to more dwell on hormonal options in terms of Marina if she's not planning, or even Depo. OC pills, lower doses are preferred because higher doses can again increase the size of the fibroid. This is a 40-year-old with another grade 3 to 5 fibroid. Remember, grade 5, 6, 7 don't usually cause bleeding issues. They only cause pressure symptoms if they're large. So what are you going to do to this lady? Again, same options apply to this lady. Oral injectable implants or IUG devices. They suppress the endometrial proliferation, the Marina thins the endometrium, causes suppression of estrogen receptors, and gives symptom relief. You can give Depo injections or Dynogest, both known to reduce the fibroid volume and bleeding. And this is another case that presented to us during COVID with a submucous fibroid, was planned for hysteroscopy, but in COVID we stopped all gynecological surgeries, and she would teleconsult with us and say she's flooding, do something. So what is the option for this lady? So we just gave her leuprolide injections. But mind you, you can't keep giving them. They are expensive. Secondly, they cause bone mineral density loss. So it's only a temporary measure. A flare reaction is seen with this. The advantages is it gives her symptom control to tide over. Eventually, she needed surgery. What are the drawbacks with these GnRH agonists? They have, unless you add low dose add-back therapy, they have a lot of hot flushes and menopausal symptoms. And if you give pre-surgery, there's an opinion that it reduces makes the tissue planes very difficult to dissect and not useful in large fibroids, high cost, and there's an initial flare always. Most common we use is leupride. Now what about GnRH antagonists? They downregulate these EGF expression, increases apoptosis, directly regulate type 1 collagen and extracellular matrix of the fibroids with a good volume reduction. The dose is 60 mg IM, that is cetrorelix. Weekly injections are recommended. The third generation is also studied. One of them is ganirelix, 2 milligrams. But the studies, as you can see in the red at the bottom, there is not much of evidence to support their routine use. But this one drug that has drawn attention, that is elagolix, it's an oral GnRH antagonist. It's now available in India called Orilissa, and it's actually used for endometriosis. They're exploring its use in treatment of fibroids at a dose of 50 to 300 milligrams. Okay? In a dose-dependent manner, it helps with endometriosis. Side effect profile is less. There are lots of articles published on elagolix for heavy menstrual bleeding in women with fibroids too. Please keep your eyes open. Now, the FDA gave approval for relugolix with add-back of estradiol and norethindrone recently in May 2021. It is yet to come to our country. Now, case 5, here's a 48-year-old perimenopausal lady who don't want an IUCD, don't want surgery, has heavy menstrual bleeding, what are other options? Till recently, we had these sperms, SPRMs, to help us. Mifepristone, ulipristal are the ones that we commonly used. Esopristone and telepristone are still in phase 3 trials. We know their mechanism of action. This was initially mifepristone used as an abortifacient and now recognized as an SPRM. And they block the progesterone receptors, also block epidermal growth factors and reduce the fibroid size, volume, and pain, effective in smaller fibroids. The dose, different doses exist, 2.5, 20, up till 25. And we have data from RCTs and our own study from AIMS, the Alka Kruplani group, have also established the amenorrhea rates are good with mifepristone. A lot of papers again exist on this. It does have cause side effects. We must be aware of the risk of endometrial hyperplasia. We're treating one problem, but we shouldn't be causing another. These are still in the research stage, telepristone. Lot of drugs. Ulipristal was a good drug till recently. It was banned because of liver toxicity. It came under the brand names of Fibroplast, Elata, Prezil, etc. Lot of contraindications it had, especially with medical disorders. And it also can cause endometrial changes which need following. Otherwise, the pathologists can get confused with a simple hyperplasia caused by this ulipristal. So we had these Pearl 1, 2, 3, 4 studies which did not actually show significant clinical harm to the patients until recently in 2020. There were liver toxicity happening with needing liver transplants. So that led to suspension of the license by the FDA, and the European Medical Agency is recommending restricting use until it reviews the side effects. India has also banned ulipristal as of now. I am not aware if this ban has been lifted as yet. So therefore, we can't use ulipristal at the moment, only mifepristone sparingly. The other drugs, danazol, gestrinone, have a lot of androgenic side effects and we've almost given up. SERMs have not enough evidence to recommend. Cabergoline, again, more RCTs are needed. Aromatase inhibitors, off-label indication, are showing promising results. That is letrozole and anastrozole. There are observational studies, but it's an off-label option for leiomyoma management as of now. The growth hormone analogs, lanreotide, also decrease the fibroid volume. Again, the evidence is very small. We can't recommend them as of now. Vitamin D, we spoke about. There are antifibrotics which inhibit the collagen synthesis there. Gene therapy is also there, as is taking up in immunomodulation, is a big thing now in cancer treatments. So it's coming up in fibroids. Nanocarriers, as I said, they're smart carriers of depot drugs that you can go and deposit within the fibroid, which will cause shrinkage. So 2 promising antifibrotics have come up, but they have undesirable side effects. And therefore, they're not in use as of now. Herbal medicines, we don't know much about it. It's not our arena, but we need to keep our eyes open for evidence in that. And green tea, as I said, gene therapy. There are 2 FDA-approved non-surgical alternatives, that is uterine artery embolization, which shrinks the fibroid by ischemia because we block the blood flow to the fibroid, and MR-guided focused ultrasound therapy. This shrinks the fibroid by coagulative necrosis, that is dermablation. Now, but both have recurrence risks. After there's a follow-up study after myomectomy, embolization and MR-HFUS, and they found the reintervention rates were highest in MR-HFUS. So with time, the fibroids can recur. So I'm afraid, folks, I don't have any magic bullet to tell you. Only thing, I will leave you with some practical points. Fibroids do not always need treatment. First of all, remember that. Don't advise unnecessary medications or unnecessary surgeries, especially if the woman is asymptomatic. Incidentally detected fibroids, just wait and watch. Expectant management is appropriate until she is symptomatic and wants treatment. Medical management is temporary. See, no medicine, all the list of drugs that I quoted, none of them make fibroids go away. They will still be there, they will still need follow-up. Patient selection should be need-based. Antagonists of all the list, they are promising because elagolix and the new drug, FDA-approved drug in US has come up, so we should wait for more evidence. Longer term studies are required with all these newer options. This is the one we should look forward to. Given a choice, many would opt to avoid surgery, isn't it? That's what patients ask us. Or even the less invasive radiological procedures, nobody wants surgery. So therefore, there is an urgent need for efficacious medical therapy. The current needs are, we need to find an effective prevention if possible, improve early detection, slow the growth with no effect on fertility, which is easy to take orally and reduces recurrence. So it's a lot to ask, but the quest for this must continue. Thank you very much.
Any questions or any queries from the
Thank you,
audience?
ma'am, for that excellent talk. Okay, when you talk about conservative therapy, you have to be reasonably sure that you're not dealing with a malignancy. Are there any options available to make sure that you're not dealing with a malignancy?
Malignancy in a fibroid?
In a fibroid, yes.
Yeah. A very good question. Whilst we tell patients most fibroids are benign, the two pointers towards a malignant change are sudden development of acute pain, and secondly, when you're scanning, is there a lot of vascularity in the fibroid? So these two should alert you that it could be a malignant change and alert the patient. And when you go for surgery, make sure you don't morcellate, you don't spread it out, take it intact and send for testing. But other than that, there is no marker as such. LDH is a non-specific marker, but there's no marker to tell this fibroid is going to be a sarcoma and this isn't. So watch out for acute pain and lot of vascularity and sudden increase in size. These are the ones that will alert you it could be sarcomatous.
How often do we need to follow up on an ultrasound if you have a large fibroid?
If they're large, subserous and asymptomatic, by large I mean anything between 8 to 10 with no pressure effects. Generally we do 2 6-monthly scans, and if they are static, we do yearly. And we ask them to come SOS if they develop any pressure symptoms.
Thank you, ma'am, for that very useful and practical topic. I request you to kindly stay back on the dais for the group photo, and requesting Rekha ma'am and Kurian sir to join the chairpersons for a group photo on the dais.
Serena, do you all use any newer drugs for fibroids?
No, actually, I wanted to chip in to tell you that we have started using ulipristal, but only for 3 months. And it is mandatory that you check the liver function test 2 weeks after starting it. But warn them, tell them it's a thing, because that is the only drug which is really effective in reducing the mass of the fibroid. And as she rightly said, it has no effect on large fibroids, only on very small ones. That is very important. Huge fibroid giving ulipristal is meaningless. Better go for surgery.
Thank you.